Level 1, the normal start. You're born today, and you look exactly like any other baby. Round face, soft features, the completely ordinary appearance of a newborn. Your parents have no reason to expect anything unusual. Neither does the doctor. There's nothing in your first hours, first weeks, or first months to suggest that anything about your face is different from the plan. This is how cherubism always begins, not at birth, but later, after a window of completely normal development. The disease is written into your DNA from the moment of conception. A mutation in a single gene on chromosome 4 called Sh3BP2, which your body inherited from one parent who may have had it in a mild form, or which arose, in some cases, as a completely spontaneous mutation in you alone, with no family history to explain it. Either way, nothing in the gene expresses itself at birth. The protein it produces is already abnormal, but your jaw hasn't yet reached the developmental stage where the abnormality will matter. That stage arrives in early childhood, and when it does, it announces itself quietly. Level 2. The first sign. You're 2 years old, and your cheeks have been getting slightly fuller for the past few months, rounder than they were. Your parents assume it's baby fat. Children's faces change constantly in toddlerhood, filling out and reshaping in ways that are normal and expected. But by your third birthday, the fullness is different. Symmetrical in a way that isn't quite typical, both sides of the jaw equally, evenly widened, like someone carefully patted both cheeks from the inside. Your parents mention it to your pediatrician, who refers you to a specialist. Inside your jaw, something has been quietly dismantling the normal architecture of your bone. The SH3BP2 protein, in its mutated form, doesn't get broken down the way it should. It accumulates. And too much of it triggers a cascade, an inflammatory reaction in your jawbone specifically, and a massive overproduction of cells called osteoclasts, which are the body's normal bone recycling units. In a healthy jaw, osteoclasts break down old bone in small amounts while new bone replaces it, a balanced, lifelong process of remodeling. In your jaw, the osteoclasts are operating without a brake pedal. They're breaking down bone far faster than it can be replaced, and the spaces left behind are filling with fibrous tissue and cyst-like growths that have nowhere to go except outward. Nobody can feel any of this happening from the inside. The growths are painless, completely painless. You have no idea anything is wrong. You're 3 years old, and your cheeks are getting rounder, and your teeth are starting to come in at unusual angles because the growing tissue beneath them is pushing them sideways, and it doesn't hurt at all. One detail that no X-ray can explain: why the jaw specifically? Your entire body carries the same SH3BP2 mutation in every cell. Your osteoclasts throughout your skeleton could theoretically behave the same way, but they don't. The lesions in cherubism are confined almost exclusively to the mandible and maxilla, the lower and upper jaw. The current best explanation involves the jaw's unique exposure to oral bacteria and the constant low-level tissue remodeling that happens throughout childhood as teeth develop and jaw bones grow. This creates a biological environment specific to the jaw that the mutated protein responds to. Other bones in your body carrying the same mutation remain entirely unaffected. It is a disease that has, somehow, a very precise address. Level 3, the diagnosis. You're 4 years old, and the specialist knows what she's looking at before the imaging is even back. An X-ray of your jaw shows what she expected. Multilocular lesions, multiple interconnected cavities where dense bone should be, expanding symmetrically through both your lower jaw and upper jaw. An MRI confirms the extent. A genetic test confirms the SH3BP2 mutation. Cherubism. She tells your parents what it is, what it does, and what the timeline typically looks like. Your parents ask what treatment is available. The specialist explains the current standard of care, which surprises many families because it sounds like no action at all. In most cases of cherubism, particularly mild to moderate ones, doctors watch and wait. Because the disease is self-limiting. Because puberty, when jaw growth stabilizes, is also when cherubism typically stabilizes. Because in many children, the lesions then slowly regress on their own into early adulthood, replaced by normal bone, the jaw returning to something close to a typical shape. Surgery exists, but it's generally reserved for cases where the growth is severe enough to interfere with breathing, swallowing, speech, or vision, or where the impact on the child's well-being is significant enough to justify intervention before the natural stabilization occurs. Your case is moderate. They'll monitor you every 6 months. They'll step in if they need to. For now, you wait. Level 4, the childhood years. You're 7 years old now, and school has introduced a reality your parents were preparing you for without quite knowing how to prepare you for it. Children notice faces. It's one of the first things human beings learn to read. And your face looks different enough from other 7-year-olds that it draws attention in the way children's attention tends to go, direct, unfiltered, without the social education yet to know when to look away or what not to say. Some children ask directly, the way children do. Why does your face look like that? You have an answer, because your parents practiced it with you. You have a condition where your jaw grows a little differently. It doesn't hurt. It might change as you get older. You deliver this with more composure than most 7-year-olds could manage something this personal because you've been practicing it since you were 5. Your teeth are a complication. Several permanent teeth haven't erupted properly, displaced by the fibrous tissue below the gum line, tilted sideways or stuck entirely, floating in the jaw without a path to the surface. Your orthodontist works carefully around the lesions. Some teeth may never come in correctly. Some have been surgically exposed to give them a route through. Your dental appointments have become a full specialty team. An orthodontist, an oral surgeon, a maxillofacial specialist, all coordinating around the same jaw. In more severe cases than yours, the expansion reaches the upper jaw far enough to push against the orbital floor, the thin shelf of bone beneath each eye, tilting the eyeballs slightly upward. This exposes the white of the eye below the iris, giving the characteristic gaze that Jones noted in 1933, the eyes looking gently skyward, which completed the cherubic resemblance that named the disease. Your upper jaw hasn't expanded enough to reach your orbital floors. But you've seen photographs of severe cases in the medical literature your parents keep, and you understand now why the doctor who first described this condition looked for a word that could hold both the difficulty and something else alongside it. Your parents have done something important during this period that your older self will recognize later as one of the most significant gifts they gave you. They've never treated the condition as the primary fact about you. It's something you have, not something you are. You go to school, you make friends, you have things you're good at and things you're not. The jaw is one chapter of the book, not the title. Level 5. The hardest years. You're 12 years old, and this is the year it gets hardest. Not medically, socially. Secondary school is a different world from primary school, larger and more anonymous, with social hierarchies that middle schoolers navigate with instruments that feel, from the inside, more like weapons. Appearance matters more at 12 than it did at 7, because 12-year-olds have developed enough social awareness to understand how other people see them, and not yet enough security to be comfortable with the distance between what they look like and what they wish they looked like. Your jaw is at its most prominent now. The lesions have continued expanding through childhood in the way the specialist predicted, and you are at the developmental peak of the disease, the point before puberty where the growth is greatest. Photographs from this year will later be the ones that look least like the adult you're becoming. This year, you have a single conversation with a counselor at school that you'll remember for the rest of your life. She asks you what you think your face says to people who don't know you. You think about it for a long time. Then you tell her you think it makes people decide who you are before you've said anything. She nods. She asks what happens when they get past that. You tell her they always seem surprised that you're funny, that you always seem surprised they're surprised. You are funnier than most 12-year-olds. You've had more practice getting people to actually look at you. Level 6. The turn. You're 15, and something is happening that the specialist has been watching for. The growth has slowed. The jaw isn't expanding at the rate it was 2 years ago. Puberty is bringing the hormonal and skeletal changes that alter the environment in which the lesions grow, and the lesions, as predicted, are beginning to respond. The osteoclast overactivity that has been driving the expansion is quieting. New bone is beginning to fill some of the spaces where fibrous tissue had taken hold. This isn't visible in the mirror yet, not dramatically, but the specialist's imaging tells a story the mirror can't. The lesions are stable, in some areas, beginning to involute. The jaw is doing what most jaws with this condition eventually do. It is slowly, quietly, deciding to stop. You have surgery this year, not emergency surgery, but a planned procedure. Jaw contouring. A maxillofacial surgeon carefully reshaping the bone where the expansion is most prominent and where it's now stable enough to work with. It's the surgery your parents and the medical team have been holding in reserve for the right moment, after stabilization, with the most information possible about where the disease has finished its work. You come out of surgery with a jaw that is already closer to symmetric than it has been since you were 3. The swelling of the surgery itself takes months to fully resolve. But underneath it, once it clears, is something new. While you were going through this, researchers were also making progress on a different front. A small number of cases of aggressive cherubism, where the lesions grew too quickly or too severely to wait for puberty, were treated with a drug called imatinib, a cancer medication that targets the same inflammatory signaling pathway that the mutated SH3BP2 protein activates. In those cases, some of the lesions not only stopped growing but actually shrank, something the wait and watch approach doesn't achieve. The research is preliminary. It involves a handful of patients. But it points toward a future where the choice isn't only between watchful waiting and surgery, where a third path exists that interrupts the disease at its molecular root. Level 7. The reflection. You're 23 years old, and people meeting you for the first time don't know. That's the part of cherubism that's hardest to convey to someone who hasn't lived inside it. That the disease, for the majority of people who have it, eventually reverses itself. The fibrous tissue that replaced the bone gets replaced in turn by new bone as the body remodels in early adulthood. The jaw settles. The face changes. By your late 20s and 30s, the medical literature says, most people with cherubism have facial appearances that are, in the words of the studies, not usually recognizable as having been affected. You are not yet at the end of that remodeling. You're 23, but you're close enough to see where it's going. The face in the mirror is yours, and it looks, more and more, like the face that was always underneath the condition. You think sometimes about the number. Fewer than 600 cases ever documented worldwide. 600 people in recorded history. That's not a population, that's a village. The research that exists about this disease, the clinical studies, the surgical outcomes data, the genetic analysis that finally pinpointed the SH3BP2 mutation in 1999, exists because those few hundred people were studied and followed, and because some of them contributed their medical data to science. One more thing, the name, cherubism. A doctor looked at 3 siblings with dramatically widened jaws and round, full cheeks and upward-tilted eyes in 1933 and named their condition after the chubby-faced angels of Renaissance paintings. It is, in a strange way, one of the more human things medicine has ever done. Not a clinical descriptor, not a genetic shorthand. A name that looked at a face shaped by something unusual and chose, of all available words, the one that meant angelic. And somewhere right now, a parent is noticing that their 2-year-old's cheeks seem fuller than they should be, rounder than expected, symmetrical in a way that's slightly different from other children they know. They'll mention it at the next appointment. A referral will follow, and a specialist will sit across from them and say a word they've never heard before. It will sound, at first, like something terrifying. It will take a long time and a long childhood to understand that it's something their child will mostly grow out of. But grow out of it, they will.